Welcome to our deep dive into the fascinating world of pain perception and its often puzzling relationship with physiological findings. Pain is a complex, multifaceted experience that extends far beyond simple cause and effect. It's not just a physical sensation, it's deeply intertwined with our emotions, thoughts, and past experiences. Understanding this complexity is crucial for both patients and healthcare providers. Today, we'll explore key studies that shed light on why pain doesn't always match up with what we see on medical scans. We often assume that if something shows up on a scan, it must be the source of pain, or conversely, if a scan is clear, there shouldn't be any pain. However, medical science tells a more nuanced story. We'll be looking at research that challenges these assumptions, revealing how the brain processes pain, and why some people experience debilitating pain even when imaging shows minimal physical damage. The goal here is to foster a deeper understanding and to highlight the importance of a holistic approach to pain management. Let's begin with a foundational concept from Dr. Ronald Melzack, who in 2001 significantly advanced our understanding of pain with his Neuromatrix Theory. He proposed that pain is not simply a direct transmission of injury signals from the body to the brain. Instead, he suggested that our brains possess a vast, genetically determined neural network, the neuromatrix that generates our experience of pain. This network integrates sensory inputs, cognitive information, and affective inputs, such as our emotions and stress levels. It's this complex interplay that ultimately shapes our perception of pain, its intensity, and its quality. The implications of the Neuromatrix theory are profound, especially when we consider conditions like phantom limb pain. This is where an individual experiences vivid, often excruciating pain in a limb that has been amputated. If pain was solely a response to tissue damage, this phenomenon would be inexplicable. However, Melzack's theory suggests that the neuromatrix, which once represented that limb, can continue to generate the sensation of pain, even in the absence of physical input from the limb itself. It's as if the brain's body map still fires off signals for that missing part, creating a very real and distressing pain experience. This highlights that pain is fundamentally a brain-generated experience. Now let's turn our attention to a very common condition, knee osteoarthritis. A pivotal 2008 study by Bedson and Croft, published in the British Medical Journal, investigated the discrepancy between radiographic findings, what we see on an X-ray, and a patient's actual pain perception in knee osteoarthritis. You might think that the worse the X-ray looks, the more pain the person would experience. However, their research and subsequent studies have shown a surprisingly weak correlation. Many with severe osteoarthritic changes report little pain, while others with minimal evidence suffer significantly. This disconnect is crucial for both patients and clinicians. An X-ray alone is often a poor predictor of pain or daily life impact. Bedson and Croft's work emphasized that focusing solely on structural changes can be misleading. Other factors such as inflammation, muscle weakness, biomechanical issues, and psychological factors play a substantial role in the pain experience. The severity of joint damage is just one piece of a much larger puzzle in understanding and managing osteoarthritis pain. Therefore, when assessing someone with suspected knee osteoarthritis, it's vital to look beyond the X-ray. A comprehensive evaluation should include a thorough physical examination, a detailed patient history focusing on the nature and impact of their pain, and an assessment of functional limitations. This study by Bedson and Croft serves as a powerful reminder that we treat patients, not X-rays. The patient's reported experience, their symptoms, and their quality of life should be the primary guides in developing a treatment plan, rather than relying solely on the degree of structural change visible on an imaging study. Chapter 3. Chronic pain is rarely just a physical sensation. It's deeply interwoven with our psychological state. A review by Gatchell and colleagues in 2007, published in The American Psychologist, highlighted the significant role that psychological factors play in chronic pain. Factors such as anxiety, depression, fear of movement, also known as kinesiophobia, and catastrophizing, the tendency to magnify the threat value of pain sensations, can profoundly influence how an individual perceives and copes with ongoing pain. The brain and our mental processes significantly modulate the pain experience. Consider anxiety, for instance. When we're anxious, our bodies are in a state of heightened alert, making us more sensitive to pain signals. Depression, often co-occurring with chronic pain, can deplete our coping resources and lower our pain threshold. Catastrophizing has been shown to be a strong predictor of pain intensity and disability. If someone constantly anticipates the worst-case scenario regarding their pain, it can create a vicious cycle, leading to increased suffering and functional impairment. Gatchell and his team's work emphasizes the necessity of a biopsychosocial approach to chronic pain management. This model recognizes that pain arises from a complex interplay of biological factors, like tissue damage or nerve dysfunction, psychological factors such as thoughts, emotions and behaviors, and social factors like support systems and cultural influences. Effective treatment often requires addressing these psychological components alongside any physical interventions. Therapies such as cognitive behavioral therapy, mindfulness and acceptance and commitment therapy can be incredibly valuable in helping individuals manage their thoughts and emotional responses to pain, thereby reducing its overall impact on their lives. Chapter 4. One of the most paradigm-shifting studies in back pain research came from Jensen and colleagues in 1994, published in the New England Journal of Medicine. They performed MRI scans of the lumbar spine, the lower back, on individuals who had absolutely no history of back pain. Their findings were astonishing to many at the time and continue to be incredibly relevant today. A significant percentage of these asymptomatic, pain-free individuals showed structural abnormalities often cited as causes of pain, such as bulging discs or herniated discs. For example, among those in their 60s who had no pain, over 80% had disc degeneration, and over half had disc bulges. These findings delivered a crucial message. The presence of structural changes on an MRI of the lumbar spine does not automatically equate to pain. Many of these findings can be, and often are, normal age-related changes, much like wrinkles on the skin or graying hair. They are not necessarily pathological or the source of a problem. This study profoundly challenged the common practice of heavily relying on MRI findings to diagnose the cause of back pain, especially when those findings are not clearly correlated with the patient's specific symptoms and clinical examination. Chapter 5. Let's explore central sensitization, a phenomenon described by Dr. Clifford Woolf in his 2011 paper in the journal Pain. Central sensitization is when the central nervous system, the brain and spinal cord, becomes hyperexcitable and amplifies pain signals. It's like the volume knob on your pain system being turned way up. In this state, stimuli that wouldn't normally be painful, like a light touch, can be perceived as intensely painful. A condition called allodynia, and typically painful stimuli, are experienced as much more severe, known as hyperalgesia. This heightened sensitivity is not due to ongoing damage or inflammation in the peripheral tissues. Instead, it's a change in how the nervous system processes information. Prolonged pain signals or certain types of inflammation or nerve injury can trigger lasting changes in the neurons within the spinal cord and brain. These neurons become more responsive, their thresholds for firing decrease, and the brain areas processing pain can expand. The pain system learns to be overprotective, generating significant pain even without a significant ongoing peripheral problem. Understanding central sensitization is crucial for diagnosing and treating chronic pain conditions like fibromyalgia, irritable bowel syndrome, and some forms of chronic low back pain or headache. When central sensitization drives pain, treatments aimed solely at peripheral tissues may be ineffective. Therapies need to target these central nervous system changes. This might include medications that modulate neurotransmitter activity, graded exercise programs to reintroduce movement without flaring up the system, pain neuroscience education, and various mind-body therapies. Recognizing central sensitization helps explain why pain can persist long after an initial injury has healed. As we've journeyed through these landmark studies, from Melzack's Neuromatrix to Woolf's central sensitization, a clear picture emerges. Pain is far more intricate than a simple signal of tissue damage. The research by Bedson and Croft on knee osteoarthritis and Jensen and colleagues on asymptomatic back abnormalities further underscores that what we see on a scan often doesn't tell the full story. of a person's pain experience. Moreover, Gatchell's work powerfully demonstrates the profound influence of our psychological state on how we perceive and cope with chronic pain. These studies collectively highlight the complex nature of pain and the importance of considering both physiological and psychological factors in its assessment and treatment. It's a call for a more holistic, patient-centered approach, one that listens intently to the individual's experience, looks beyond the images, and integrates strategies that address the multifaceted dimensions of pain. This understanding empowers patients to be active participants in their healing and encourages clinicians to broaden their diagnostic and therapeutic toolkits. Here at Bethesda Spine, we are committed to embracing this comprehensive understanding to provide the best possible care. Thank you for watching this exploration into the science of pain perception. We hope this has been informative and has provided you with a deeper appreciation for this complex human experience. Don't forget to like, share, and subscribe for more insightful content on medical science. Your engagement helps us continue to bring these important discussions to a wider audience. Stay informed and be well.